we are going to save questions towards the end of the symposium, if that's okay.
Yeah.
Yeah. Thank you.
We're done.
Yeah, at the end.
Of course.
Thank you. So our next speaker does not need any introduction for this audience. So let me invite Prof. Mark Gurnell to talk about acromegaly and optimizing treatment in 2025. Over to you, Prof. Gurnell.
Again, it's great to be here. And Miles, thank you for setting this up nicely. So some of the topics that Miles has just run through will be a little bit duplicated here, but hopefully that will reinforce the messages. So I do have one or two relevant disclosures for this. Perhaps one to point out is that I will refer on several occasions to acromegaly consensus guidelines, and I actually sit as one of the members of the consensus group. Just to make Miles smile, the other thing about consensus guidelines is that they may allegedly be written by experts who then largely don't really follow the guidelines because they're a compromise between lots of people in a room. So if you ask any individual expert whether they follow their guidelines meticulously, you might get a slightly strange view. Okay, so clinical context. This is very familiar to everybody. Acromegaly is actually probably more common than the textbooks say it is, but still counts as a rare disorder. It's a multi-system condition, and not surprisingly, it requires multimodal therapy. But there's one really important message that I would now say are the new headlines for anybody that you meet with acromegaly in 2025, at least theoretically. And of course, there's going to be some issues relating to resource allocation, what's available to you. But the headline is, the recent advances in treatment mean that actually when I now meet a patient with acromegaly, I pretty much always tell them at the start that this doesn't feel great at the moment, but I'm now very, very confident that I will be able to control your disease. Because for the first time, I now have a whole array of different tools available that will allow me to get control of disease for the majority of patients. And this is a really important thing to be able to tell somebody when you are sitting down with them and actually having a 20, 30-minute consultation and appearing to list all the things that could go wrong and that can actually make that patient feel quite intimidated. So actually being confident with them because of the tools that are available to us now in 2025, including the fact that we're going to see some new agents through very, very shortly, means that we should be very, very positive. And this means that we should be very proactive with the management of patients with acromegaly. Nearly well controlled is now not good enough. They should be controlled if at all possible. So the reason this is important, because people with acromegaly have a substantially impaired quality of life for lots of reasons, as we'll see. But I start with this one because it's often not appreciated that if you compare people with acromegaly to other people with other diseases, they don't fare very well. But actually when we improve their condition, they often improve dramatically. This is actually a really nice study from colleagues in the Netherlands. This is Nienke Bierma's group. And in essence, they used they performed a meta-analysis, a systematic review and meta-analysis, and they looked at studies which were intervention studies and cohort studies. Panels A and B are using the AcroQoL, which is the Acromegaly Quality of Life Specific Questionnaire, and showing that actually when you intervene, that the AcroQoL score improves, so that's moving over to the right-hand side on the top panel A, and also in the cohort studies, again showing that patients with acromegaly do have this potential issue, and again panel C is using a different questionnaire, which is the patient-assessed acromegaly symptom questionnaire, and again showing that patients actually have a lower quality of life. And this translates, for example, if you compare it to patients with chronic rheumatological conditions, so these are patients without major disability, but either with, for example, osteoarthritis of the knee or hip or hand, etc., comparing the patient with acromegaly to the patient with a chronic rheumatological disorder where you would expect quality of life to be impaired, here we have lower scores and therefore higher rates of mental health issues related to depression scores in the patients with acromegaly. So it's really important that we don't underestimate the impact that this has on the patient. Also, up front, I want to highlight the comorbidities. It's interesting how when you consult with a patient in acromegaly, you often want to focus on the IGF-1 or the growth hormone or what the MRI scan shows. But actually the thing that often leaves the patient in the long term suffering the most other comorbidities that we have or haven't paid due care and attention to. So it's really important. This is a study we did I started this study 20 years ago. We reported it 10 years ago. And this was just making a very detailed assessment of the level of complications of newly diagnosed patients with acromegaly. The study actually was looking at intervention with primary medical therapy. And what that means is that we now have, and this is one of the consensus documents for 2020, but we are just about to submit for publication the 2025 revision to this document. These are the things that we now need to be thinking about with a patient with acromegaly in front of us in terms of what are the cardiovascular complications they're suffering with, be it blood pressure or be it problems in relation to cardiac performance. Miles has already mentioned in the perioperative period issues around sleep, and I'll show you some data in a moment which says we really need to gear up on this and actually catch up with the fact that many of these patients have problems. Other endocrine issues, metabolic issues, and then due to the work of Andrea Giustina and colleagues in Milan, we now have a really good appreciation of the really awful musculoskeletal problems that these patients have. We still need to recognize that cancer of certain types, colonic polyps and indeed cancer, and probably some thyroid cancers are slightly more common, although it is debated. And then I've mentioned the quality of life. So where are the big changes going to come in the 2025? These are the anticipated changes. There's going to be overt reference to lipids. We're going to start recognizing that standard ways of assessing the bone, such as a DEXA scan, are not particularly very good for detecting the patients with acromegaly who are at risk of fractures. And therefore, we actually either need to use plain imaging or CT imaging, or indeed generating, for example, a trabecular bone score. We're also going to be recommending potentially some more investigation from a cardiac perspective. Now, this won't be available to everybody, but cardiac MRI is probably more informative than doing simple echocardiography, but echocardiography will still suffice for most patients, and polysomnography. And one of the reasons that I'm very interested in this is that in that earlier study I mentioned, we actually took 40 patients with acromegaly, newly diagnosed, and we put them through full polysomnography. So that is not just doing oxygen desaturation, for example, or questionnaires. This is actually working out how many patients have apnea or hypopnea. And the long story short is that we see that patients, as judged by the gold standard of polysomnography, have very prevalent, 79% of the case cohort had sleep apnea. But if you just did finger oxygen monitoring at home, you either failed to diagnose it or you underestimated the severity. And if you use a questionnaire such as the Epworth Sleepiness Scale, the majority of patients didn't even trigger a positive result. The patients didn't even realize that they had features that were compatible with sleep apnea. And when you look at their sleep phases, you find that most of the patients with acromegaly spend most of their sleep in the early lighter phase, stage 1 or stage 2 of sleep, and rarely hitting the slow wave sleep, or indeed the REM sleep, which is the refreshing sleep. So these patients are not aware that they've got problems with sleep disordered breathing, but they have very severe problems with sleep disordered breathing. And so the new guidance will now recommend that polysomnography itself is the investigation for everybody, not any form of screening beforehand. So a couple of updates on diagnosis. The consensus group published last year some updates just to emphasize some key messages. Again, Miles has referred to some of these. Just as per my previous talk on thyroid function tests, it's really, really important that we have access to robust and reliable measures of IGF-1 and growth hormone. You may think that your laboratory is okay, but we know that there are big problems still in 2025 with IGF-1 measurements and also some growth hormone measurements. So know your assays, know the factors that are influencing those. When you get a different result, check with the laboratory. In a patient who's been stable for a long time and the result changes, the patient may not have changed. It may be that it's a laboratory assay issue. Because of our colleagues on the other side of the Atlantic, there's a sort of inclination now to use IGF-1 on its own to be sufficient for diagnosis, although Miles and I were discussing this the other day. We still pay quite a lot of attention to growth hormone levels, and certainly anybody with an equivocal set of results, the glucose-suppressed growth hormone is still probably the key investigation. But note the bottom line. We are probably not using the right thresholds. For years we were stuck on 1 microgram per litre, then we dropped to 0.4 micrograms per litre. Beautiful work by Katharina Schilbach and colleagues in Berlin and then Munich has actually now demonstrated that actually we probably should be using different, even lower thresholds depending on the sex of the person, and also depending on the BMI, etc. And that actually is a very low threshold for defining that somebody is normal. Also, just to remind you that we are not talking about cure anymore, we're talking about remission. Why do we talk about remission? That's because actually sometimes the disease is still there, but we simply can't detect it. We don't actually even now have perfect timing for knowing exactly when we should assess people following interventions, but again, Miles has alluded to this, we certainly for IGF-1 need to wait at least 12 weeks. The early growth hormone, however, and again Miles mentioned this, can be a good indicator of whether you've actually managed to put that patient into remission, but I've also alluded to the GTT. And don't forget, if you've treated the patient with, for example, somatostatin analog before surgery, you now need to delay your testing even further, because that can influence the post-surgical results. So, what do we need to do now when we're managing a patient with acromegaly, bearing all that in mind? Well, first thing is we need to take a holistic approach. The signs, the symptoms, the patient's worried about what their scan shows with the tumour, they're worried about what their IGF-1 level is doing, they've now been told they may have a whole bunch of complications. We cannot ignore any of these. We need to bear all of these in mind, which makes the consultation quite a tricky consultation because there's many different factors that we need to be addressing. But if we don't stop and think about these each time, we will undertreat the patient. So the guiding principles are know your laboratory assays. I've already made that point before. Manage your comorbidities and keep control of those symptoms wherever possible. Transphenoidal surgery remains the primary treatment for acromegaly, as we'll see shortly, but medical therapy is effective and is actually very much the second-line therapy, if not for some patients first line. Radiotherapy is still here, still has an important role to play, but for most patients is now down in the third-line category. And very, very importantly, you need to be in a centre that knows what it's doing and has access to all the relevant expertise. And again, Miles has already mentioned the critical importance of a high-quality surgeon for favourable outcomes in these patients. So acromegaly-directed treatment. So surgery is first-line therapy, but I'll show you in a moment that it can also be the second-line and occasionally the third-line therapy. It has benefits, it gives immediate results for all the reasons that Miles has alluded to, but of course it is a surgical procedure and it has surgical and anaesthetic risks. But in our other consensus document from 2020, we highlighted that actually the factors that potentially have predictors of outcomes from surgery, and we also highlighted the potential rates of remission that you might expect, be it a microadenoma or a macroadenoma. Not surprisingly, the bigger the tumour, the more likely you are to have residual disease afterwards. But even when you know you're going to leave residual disease, debulking can still dramatically change the long-term outcome and course for that patient because you leave a lot less for the medical therapy to deal with. I've already mentioned the fact that you need to leave long enough after surgery, so don't act too quickly if the IGF-1 is still a little bit high, especially if the growth hormone immediately post-operatively is low, unless 1 microgram per litre is a very nice result to see because that has a good predictor of long-term remission. Critically, the expertise of the surgeon, as we've talked about, is really crucial. Reoperation is definitely now something we should be thinking about. When I first trained as a pituitary endocrinologist, pretty much most patients got 1 operation, and that was it. And then the surgeon said, I'm done. Now, in our centre, we are frequently doing the 2nd, the 3rd, or even the 4th operation. This is a revisit, as and when we need to do so, especially if the patient has been operated on a centre without that particular expertise. So I want to just show you one case that illustrates this. This is a patient sent to us who had residual disease. You can see the extent of the tumour. You can see the left cavernous sinus disease. The patient's had a good debulking, but still has acromegaly. This is a volumetric sequence. This means that we've taken very fine slices through the cellar. These are 1 millimetre slices through the cellar. And in essence, this gives us an ability to almost draw around where the tumour is on the left-hand side there. It looks as if it's actually at least a NOSP3A tumour, this. So most centres would say, I'm sorry, but you're unlikely to be subject to curative surgery or surgery that will put you into full remission. I'm not going to spend long talking about this. This is a particular type of molecular imaging, a PET scan. In this case, the PET scan not only shows the normal gland, which is the area in the middle, but it shows with the yellow arrow where the residual tumour is. And the reason it's crucial is because it shows us the limit of the tumour, which actually we were able to reconstruct into 3D using the CT, the MR, and the PET. And this was important because it allowed our surgeon to get a view, as you'll see it coming around, that the tumour is sitting on top of, but not going really much beyond the carotid. And that actually persuaded us to then reoperate on this patient. And this was nearly a decade ago, and this patient remains in complete biochemical remission, requiring no other treatment. So this is repeat surgery in a centre which has experience of doing this. These were the first patients that we took, the first 9 patients who were deemed to have surgically unresectable disease, who we then took on for surgery. And these are patients who then went into remission without requiring adjunctive medical therapy. And I was very fortunate 2 years ago to have Linus Haberbosch, who is an extremely able fellow from Christian Strasberger's group in Berlin, come and spend 4 months with me. And he went through all the patients referred to our national UK PET imaging service for acromegaly in a decade, many patients referred by Miles and his team. And essentially we looked at the indications for those patients having PET, and then we presented the results of the third of the cohort who were exclusively managed in Cambridge, i.e. by a single surgeon operating, so we had a lot of control over the outcomes. So remember, these are patients who were sent to us who've been heavily treated, surgery, radiotherapy, medical therapy, often in combinations. And we were being asked, the MRI doesn't show us where the tumour is, or in a small number of cases we couldn't see the tumour at the start, or we want to think about some more definitive intervention, be it surgery or radiosurgery, but we don't know where the tumour is. And therefore, documented clearly was, we are unlikely to proceed with further surgery unless somebody can show us some good evidence to do so. And what this found was that in 61 patients managed entirely through us locally, in 52 of those patients, the molecular imaging located the residual tumour. Now, not all of those patients were obviously clearly suitable for surgery. Some went to radiotherapy and some to medical therapy, but actually 33 did go. Remember, these are 33 patients who were told no more surgery, and 24 of those patients achieved full biochemical remission. And that is the change of the IGF-1 levels in this group of difficult to manage cases. And we saw 3 additional single hormone deficits in this surgically challenging group. So this is safe surgery and effective surgery, which prevents long-term additional medical treatment requests and radiotherapy. So this is really important that we remember that actually finding a good surgeon could be the end of the process for the patient, and more surgery may be indicated. Radiotherapy, just to briefly mention, still has a role to play for persistent tumour, but it's largely relegated to second or more commonly even third line treatment now. It is effective, but of course it takes time in most patients to work. There are lots of different types of radiotherapy. The key things you need to remember are that modern radiotherapy should be stereotactic. What does that mean? It means that it has all the technology available to perfectly map the shape of the tumour to deliver maximum therapy to the tumour with minimal fall-off. Just because you hear the term stereotactic radiosurgery or gamma knife does not mean that actually standard radiotherapy isn't as good or as accurate. The only advantage of gamma knife is because you can deliver it all in one potential fraction or a small number of fractions. And you don't need to use a gamma knife machine. You can use an ordinary linear accelerator to deliver radiosurgery, which of course can also deliver fractionated radiotherapy. CyberKnife, which is an amazing development, which also delivers stereotactic radiosurgery and is a robotic frameless form of stereotactic radiosurgery. Proton therapy, which is a different approach of course because it uses protons rather than photons. And then we don't really need to use this much in acromegaly, but for the record, we can obviously use PRRT as well, theoretically. So tumour endocrine control depends on the type of disease you're dealing with, but it's pretty good for tumour control. Endocrine control, as we'll see in a moment, is disease dependent, so I'll show you the acromegaly data. It's also technique dependent. The speed of biochemical control is quicker with stereotactic radiosurgery than it is if you use more fractionated, because you're giving a bigger dose all in one go. So in acromegaly, we know major headlines are tumour control. That means not suffering with mass effect more than 90%. In fact, I've just been reviewing the data for this, and it's more than 95%. So really confident that we can stop your tumour misbehaving. Biochemical control, i.e. endocrine control, around about 2/3 of patients. That might be control and still needing some medical therapy, or it might be proper endocrine remission. I need no additional therapy. There are some toxicities, hypopituitarism of course, Hopefully it's quite rare to see visual pathways issues. Cerebrovascular disease is still a talked about issue, but with modern radiotherapy techniques, we still need to work out whether actually the premature cerebrovascular disease is more the primary underlying disease rather than it is potentially irradiating the carotids. The risk of second brain tumors is probably dropping off really significantly now we're using much better techniques. The data really comes from old 3-field radiotherapy, and so for the cognitive deficits in the temporal lobes. So I want to spend the last couple of minutes on the medical therapy, and this is where all the big gains are being made and are about to be made. We now have an amazing potential array of tools subject to funding available, and certainly not everywhere, and Miles has alluded to the fact that in the UK we still don't have access to all the drugs that I watch my colleagues in other parts of Europe and North America have. But medical therapy could be first-line therapy, but it's certainly excellent for patients who've got some residual disease post-surgery. At the moment it resolves around first or occasionally second-generation somatostatin receptor ligands, small amount of dopamine agonist use, and growth hormone receptor antagonists such as pegvisomant. And this is hot off the press. This literally was not published when I got on the aeroplane, but by the time I got off the aeroplane to get here, this is our latest consensus guidelines on the management of acromegaly, just published in Nature Reviews 2 days ago. So I'm going to break this down into 2 bits just for the last couple of minutes to focus on. The first is the top of the algorithm that says, what should we do? Well, it points out quite clearly that surgery remains the first-line treatment. But now we are trying to give people some guidance on when to use different types of medical therapy in an ideal world. So dopamine agonists still have a potential role if you've got a mild persistence of disease afterwards, mildly elevated GH and IGF-1. Certainly if the IGF-1 is less than twice the upper limit of the reference range for that patient, then you could consider bromocriptine or cabergoline. What about medical therapy? Well, if you've got a classical patient with acromegaly in terms of tumour that looks like it'll respond to first-generation somatostatin receptor ligand, i.e. octreotide or lanreotide, what are the features to that? Hypointense signal of the tumour compared to the adjacent temporal lobe on T2. High SSTR2 expression if you're lucky enough to have immunohistochemistry, which actually most centres still don't have. But at least your pathologist should be able to tell you if it's densely or sparsely granulated. Densely granulated, good predictor of response to SRL therapy. And low baseline levels of GH and IGF-1, injectable somatostatin analog, octreotide or lanreotide. We don't have it in Europe, but if you're in North America, you could consider oral octreotide. So this is a very clever preparation of octreotide, which has it bedded within a tablet, which essentially has an element in there that allows the gap junctions in the intestine to be temporarily opened so you can actually get the peptide in. The problem with this is actually you can't eat at the same time and you have to take it several times a day, so I don't think this is actually likely to be that attractive, but some patients prefer it. If you do not have any particular concerns about residual tumour, but you have actually got a patient with impaired metabolism, in particular diabetes, then pegvisomant potentially is a really good choice if you have access to it. So that's the first line. What happens if the patient still has inadequate disease control? Well, what we wanted to do is provide guidance. If the IGF-1 levels are still modestly elevated during SRL therapy, you can actually increase the dose even higher than the actual maximum. So Andrea Giustina has beautifully shown that, for example, with autogel, lanreotide autogel, you can go up to 180 milligrams, even though 120 is officially the top licensed dose, or you can reduce the interval so that you inject every 3rd week instead of every 4 weeks. You might want to add cabergoline in and get synergy between the 2 drugs. If you don't have any concerns about the adenoma, then think about pegvisomant coming in. Don't forget this is now add-on therapy rather than solo therapy. If you've got worsening glucose metabolism because the SRL is actually impairing insulin production, etc., or worsening glucose homeostasis, I should say, worsening glucose control, then maybe just switching to pegvisomant. And then at the moment, the 2nd-generation somatostatin receptor ligand, pasireotide, remains out at the end here because of its abnormal effects on glucose metabolism, causing diabetes in 2/3 of patients who take it, but it is reversible. But if you have problems with tumor control, this drug can make a difference because it is a much more potent ligand at SSTR receptor 5 than 2, Well, it acts at 2 very well as well, but in particular at 5, which lanreotide and octreotide don't do. So that can give you tumor control. And if you're really stuck, then you start coming down to radiotherapy, combining, for example, pegvisomant with pasireotide. Of course, if you're in the very small group of patients with a really aggressive tumor, you might think about temozolomide. So this is now a single figure which really encapsulates in 2025 what optimal medical therapy for acromegaly should look like. And it's this data which is why I'm very confident that we should be able to get control. And also because of this. Down the bottom are all the drugs we already have. At the top are just 3 examples of drugs which are already now at the end of their phase 3 trials. Paltusotine, which is a really exciting non-peptide molecule produced by the company Crinetics. Oral, once a day, 1 hour gap before you eat, produces extraordinarily good control in patients who were on somatostatin analogues beforehand. And we will see that shortly. Modified versions of octreotide for injection. And coming down the line, a whole host of other exciting ways of tackling this, new GH receptor antagonists, and whole new ways at the bottom of actually moderating GH signaling, including through the use of antisense oligonucleotide strategies as well. So this is an exciting time. So I'm going to finish by saying we must continue to think about all these things. This is your job when faced with a patient in the clinic, is to consider all the things that are troubling the patient, but now be optimistic. Because now the patient needs to know that you are aware of all the things that need dealing with and you have the toolkit, or at least theoretically you should have hopefully access to the toolkit, accepting limitations that will allow you to deal with that. So I'm going to finish at that point, say thank you very, very much for your attention, and I know that we will move to questions at the end, but thank you again.
Thank you, Professor Gurnell, for the wonderful presentation.